and there are some studies out there where it looks like women who are placed on oral contraceptive actually have a decreased likelihood of the return of spontaneous menses.
Anyway, next recommendation is we suggest against patients with FHA using oral contraceptive pills for the sole purpose of regaining menses or improving bone mineral density.
So just because the patient has a menstrual cycle doesn't mean you've solved the problem?
Correct. So obviously in this case, if the patient is seeking out medical services to improve current or future fertility, they likely would not want this intervention. I think that's all we need to say about that recommendation.
Yeah, and there are some studies out there where it looks like women who are placed on oral contraceptive actually have a decreased likelihood of the return of spontaneous menses, and perhaps because then, things appear to be functioning as they should, and they may have the perception that, okay, I'm healthy again. I'm protecting my bones. My hormones are balanced, and I guess they are to some degree, but it's not a true recovery is what I'm trying to say.
So how is this unique to hypothalamic amenorrhea? Maybe every patient starting an oral contraceptive should be counseled regarding that risk.
So they shouldn't be taking them for the sole purpose of managing acne?
What if they just don't want a menstrual period? This is just another good, and we have an episode just on oral contraceptives. This is another good microcosm of the need for true shared decision-making being done with a patient. So they're actually aware. Oral contraceptives, as we've said, is just synthetic hormone replacement therapy. They're synthetic hormones, and they are more complicated than HRT. So if your doctor is not extremely comfortable managing HRT, then perhaps you don't want them managing your synthetic HRT. And as we've said before, yes, being able to choose when or when not to conceive is perhaps the biggest benefit that there is in medicine, because it's going to benefit you, like all the different pillars of life and your entire family and such. But again, the nuance in that is choosing when to or when not to. So oral contraceptives are certainly certainly good at decreasing the chance that you conceive while you're on them, but not necessarily good at helping you conceive after you get off.
That's very true. And another thing you said there, I think, is really a gem for our listeners, because we get questions about, how do I find a good doctor? And if you put out the feeler question, how do you feel about hormone replacement after menopause? And let's say that doctor, PA, nurse practitioner says, oh, I don't do anything with that. It's too complicated. But then they're putting a large percent of their population on oral contraceptives, then they probably don't have a good grasp on hormones overall, because as you mentioned in the past, and I agree, HRT in postmenopause is actually less tricky because there are many fewer options. It's just a higher risk patient population. So
we can even take this. We can take this a step further. How do you feel about bioidentical hormones? For example, a very low dose of testosterone in a female that is deficient while they're on an oral contraceptive before menopause using bioidenticals. And conversely, how do you feel about using a scary synthetic hormone in specific scenarios after menopause?
So maybe that's the second follow-up question. If they get the first one right, they say, oh yeah, hormone replacement for women with after menopause makes sense. Then you follow up with, what about testosterone premenopausally while someone's on an oral contraceptive? Or what about synthetics after menopause? If you really want to, I guess, see how elite your hormone expert is.
What percent of providers would you say would pass all three questions in that test? It's got to be
single digits.
It's got to be low, probably 1% or 2%.
Yeah. Anyway, it gets a bit of a rabbit trail there, but this is another interesting point about oral contraceptive pills. The recommendation 3.5 in patients with FHA using oral contraceptives for contraception, we suggest educating patients regarding the fact that OCPs may mask the return of spontaneous menses, kind of just talked about that, and that bone loss may continue, particularly if patients maintain an energy deficit. But since these women, they may be getting 20 or 30 micrograms of synthetic ethinyl estradiol, doesn't that mean that any woman who is suppressing hormone production on an oral contraceptive might also be at risk for bone loss?
That is a good assumption to make. I like the phrasing. This is verbatim. The fact that OCPs may mask the return of spontaneous menses. So we'll just meditate on that as we consider shared decision-making protocol for OCPs once again.